Well, welcome everyone to the Breakthrough Challenge Symposium, and thank you to the board members, participants, and supporters that are joining us virtually today. My name is Ravi Amirvadi, and I'm the Associate Director for Translational Research at the Abramson Cancer Center. I'm filling in for Bob Vonderheide, the Cancer Center Director, who sends his apologies, but as we speak, he is speaking with Senator David McCormick to really push NCI funding right now. That's the reason why he couldn't attend. And so he sends his apologies. But now the Breakthrough Challenge is in its 13th year, and it has raised more than $3.1 million for breakthrough research at the Abramson Cancer Center, supporting really creative and essential projects. And this has funded over 70 faculty members who get these grants in the name of Richard Buzz Cooper. It's a Buzz Cooper Scholars Program. So today you're going to hear from six of these recipients about how this funding has enabled them to ask new questions and explore new avenues of research, all with the important goal of improving patient outcomes and experience. So we are so grateful for the Breakthrough Challenge Board for providing countless opportunities for our faculty. Just as an aside, I have personally received funding from the Breakthrough Challenge, and we've converted that money into DoD funding for a much larger grant and have found some really interesting findings. But today we're going to really hear from six new rising stars about their research. Before we get started, I want to say we're grateful for the sponsors, the participants, the volunteers, all of who make the bike ride so successful. This year, the bike ride is on September 27th. That's a Sunday, so put that on your calendars if you haven't already. And that's the in-person bike ride at the Daniel Boone Homestead. But there's also a week-long virtual event for people who cycle at home or run and so forth. So now let's turn our attention to the 2025 Cooper Scholars. And so please use your chat to submit questions as you hear their presentations. And at the end of the session, we'll have time. I'll go to the chat and we'll look at those questions. And also, please mute your mic so that we don't get any interruptions. So, kicking us off is Dr. Arthur Costa. Arthur, along with Dr. Bruno Barafaldi, who couldn't be here today, is going to tell us about how AI is being used to improve breast imaging and diagnosis. So, Arthur, please take it away.
Thank you. Thank you a lot, Ravi. And then welcome everyone. Let me just share the presentation here. Today I'll be filling in for Bruno Barofaldo. He couldn't join the meeting today. Mm, so just making sure that you're seeing my presentation.
Yep, we can see it.
All right. Yes, as Ravi introduced, we're applying AI tools to improve breast cancer screening diagnosis protocol. And the goal here is really to address a challenge in breast cancer screening. So to identify and really differentiate the lesions that are truly need an intervention from those that were probably not going to become dangerous in the future. So for a little bit of background on this issue that we have in breast cancer screening. So during the screening, there are more and more along the years, more and more people and more breast lesions have been detected in a very early stage. And among the modalities that are used for imaging and risk are used for risk assessment, there is magnetic resonance image, which is one of the most sensitive modalities for detecting lesions that otherwise would go unseen, especially in very dense breasts. But there is also a trade-off that comes with it, because some of the lesions that are identified as high risk turned out to be benign. So this raised some false alarms. And along with that, in the high risk category, there's a very wide range of malignancy probability that ranges from around 2% to 95%. And this raises some uncertainty in the diagnosis pipeline and includes more and more some uncertainty in the process, and this leads to a lot of patients undergoing um, some other interventions, some more invasive intervention, as well as biopsy. So some of these uh, high risk lesions that are biopsied, they returned benign. So it turns out they were benign lesions. And that not only in that has some consequence not only for the healthcare cost as well as the radiology's workload, but also for the patient anxiety throughout this whole diagnosis process. So one way to address that is our project goal is to use AI tools to help to add another layer to stratify risk assessing breast lesions related to breast cancer. So we integrate different kinds of modalities and information. So integrate imaging, other biological and clinical information into the AI models so that we can distinguish and really find what are the features that are linked to more dangerous disease. And the goal here is not to replace the radiologist, but rather provide a support tool for the decision making relative to this risk assessment and then the further interventions that are necessary. And one key aspect of this is the model explainability. So instead of just having an output like a prediction as a black box output prediction, the system is capable of generating attention maps where some of the features or regions that are highlighted helps to understand what was used to arrive to that decision. And that also helps the model to be more trustworthy so we can know what it was looking at, what was the reasoning behind what the model has, the information that the model provided, and also for future clinical use. So the goal here by the end is to really stratify this risk. So really create a more clear boundary of who needs um, to go on and have another procedure and who are also classified as low risk cases and avoid unnecessary procedures, as well as still maintaining a high cancer detection rate. So if successful, this system, this approach, it can lead to several clinical benefits, such as to reduce the benign biopsies and also reduce unnecessary procedures, um, make a shorter diagnostic pathways that soothes and gives reduces the emotional burden for the patients, have a personalized care also based on the risk as well. And from the healthcare perspective, if the specificity of this whole detection and diagnosis increases, it also will lead to less healthcare costs and lower patient anxiety. So another thing to highlight is that we are not here trying to make a new detection tool as we are used to see in most of these AI applications, but rather we are seeking for a better decision making. And in this process, as an outcome, every benign biopsy that we can avoid is a win for patients and for the healthcare system. And also, this work is only possible through a collaboration of several different professionals that comes from AI, imaging, cancer research, clinical radiology, and so on. Thank you very much for your attention. I will take questions from now on. Thank you.
Great, Arthur. That's really quite exciting how this technology is really entering research and possibly making things better. Can you just lead us through how many patients does it take, or how do you get this to the point where it can be used at other hospitals or other countries? Is that like a short road, or is that going to be a long process?
Right. So, in terms of numbers, is it still the kind of model that still requires a lot of data to be trained on? So, right now here in the hospital, we're using around 6,000 cases, sorry, for this to have a more broad experiences of the cases that we are facing. The thing about translating and like importing the system to other places is how much we're able to incorporate a big variety of patients, and that's something you're trying to address, like even including things like race and what the ages of the patients as well. So we also trying to bring this here to this system, and also trying some partnerships with other centers in other places besides here in the UPenn, so we can make this work with more robustly.
Yeah, even within UPenn, you have a number of hospitals that you can see the variation of different patients as they're coming in. So it's really exciting. And are there the AIs that people are using, is that anything to do with what you're doing, like the Geminis and the ChatGPTs and so forth, or are you writing does this have to be its own specific program or language model?
It's also linked to them in some ways, although they mostly have been working like they structured that how they deal with the language. So all the clinical reports and this kind of stuff, it's something very similar to what Gemini and ChatGPT use in their technology. So to extract information from those reports. So we try to link those informations with the imaging data that we have. So and but there's also some of the models and systems that we use are more specified for this kind of task. So it's not that broad as those used for the ones you just cited.
Great. Well, thank you so much. We're going to shift gears now, and I'm going to introduce Emily Bomren, who's going to be talking about immune profiling of graft versus host disease using some really exciting new technology. So, Emily, take it away.
I'm actually not going to use any slides and instead use this time to tell you about a patient of mine, Sam. So, Sam was diagnosed with acute myelogenous leukemia, which is an aggressive form of leukemia that required chemotherapy followed by a stem cell transplantation, where a sibling donated their stem cells to Sam, and those stem cells became his own immune system. With the combination of chemotherapy and stem cell transplantation, his leukemia was in remission and he was doing great until he incurred a devastating but unfortunately common complication of stem cell transplantation, which is called graft versus host disease. And this occurs when the immune system that is new to Sam attacks various organ systems and tissues. So he walked into my clinic and I'm a dermatologist because the graft versus host disease had started to attack his skin. And over the preceding weeks, he developed thick, bound down skin from just below his chin all the way to the bottom of his feet. He described it as feeling like he had been wrapped in duct tape, and it was impairing his quality of life tremendously. He wasn't able to bend over to put on his shoes, and he had loved to play golf, but wasn't able to move his arms or his waist to be able to swing that golf club. And so we started a treatment journey together, which included a first step, which was steroids, which have a lot of side effects and didn't actually improve his disease. And then over the preceding 3 years, we cycled through treatments. We started one, we waited 3 to 6 months, it didn't help, or he had a toxicity, and then we moved to the next. And it took 3 years to find a combination of treatments that finally started to help Sam's graft versus host disease. His skin became a little bit softer, his function improved, his range of motion improved, and over time, he was able to get back to his golf game. So this is the problem that I'm trying to solve with my study, which is can we move from a trial and error treatment approach to a precision medicine paradigm for graft versus host disease? And to do that, we're embarking on trying to define predictive biomarkers of treatment response. So, in order to do that, we performed a study titled Defining the Immunologic Profile of Cutaneous Chronic GVHD Treatment Responders Using Spatial Transcriptomics. And what we did is we enrolled patients with skin chronic graft-versus-host disease, like my patient Sam, and we obtained skin biopsies before they initiated treatment with a common second-line therapy called ruxolitinib, which is a JAK1/2 inhibitor. We then followed these patients for 3 months for clinical response, and we marked them as either responding to treatment or non-responding to treatment. We then performed a new state-of-the-art technique on this pre-treatment skin biopsy specimens called spatial transcriptomics using the Xenium pipeline. And this technique allows us to look at the gene expression of 5,000 genes within the anatomic architecture of the skin itself. So you can see immune cell niches and architectural niches in the top layer of the skin, the middle of the skin, and the deep layers of the skin, and look at differences in gene expression throughout. We compared gene expression between patients who were responding to treatment and those that were not responding to treatment. And in our analysis, we found there were 200 differentially expressed genes that were associated with response to treatment with ruxolitinib therapy that were not present in the patients who did not respond. We're now working right now to refine these 200 differentially expressed genes to develop a biomarker signature that would allow us to predict response to ruxolitinib therapy. So the next step is to be able to translate this biomarker signature back into the clinic and into clinical trials so that we can test out precision medicine approaches to GVHD therapy, reducing toxicity from multiple treatments over time, and then improving efficacy and quality of life. So moving back to the patient Sam, who I've followed for many years now, the goal would be to take a skin sample when he first showed up to me, 3 weeks into developing his skin symptoms, be able to define the immunologic profile as a biomarker response, as his biomarker signature as a responder or a non-responder. And if he was a responder, to start him right off the bat on ruxolitinib therapy. And if he was a non-responder, to pursue alternative FDA-approved therapies and hopefully achieve a clinical response within months as opposed to years for this patient. And with that, I will conclude and leave time for questions.
That sounds amazing, Emily. So, tell me about how do you biopsy these patients to get that tissue if their skin is so fragile or, painful?
Yeah, so we do perform, I mean, skin biopsy is an invasive procedure, but we are able to do it even on sclerotic or bound down skin. We do numb the skin before we take the sample, and we take a 4 millimeter punch sample. So it gets all the layers of the skin that we can evaluate using the spatial transcriptomics. So we really get an idea of pathophysiology from the superficial to the deep layers of the skin. And then we put in a stitch typically to put the skin back together. But the need for a skin biopsy is definitely a barrier to the success of a biomarker because you want it to be easy to collect and able to be collected on many patients. And so actually stemming from this work, we are planning to look at the correlation between our findings, our differential gene expression that we found in the skin biopsy specimens with something called tape stripping. So tape stripping is actually when you apply tape to the top layer of the skin. You remove some stratum corneum, which is the top layer of the skin, and then you repeat the tape strip over and over again, getting deeper and deeper layers of skin cells. And this has been shown in different chronic inflammatory skin diseases like eczema, psoriasis, and even in some skin diseases where the pathophysiology is a little bit deeper, like alopecia areata, which occurs at the bottom of the hair bulb. There's been excellent correlation between skin tape strip single cell RNA sequencing or the transcriptome and the skin biopsy RNA sequencing transcriptome. And so we're going to look to correlate our findings in skin tape stripping, which is a very easy non-invasive procedure for obtaining transcriptome information.
That's really cool. Can you talk a little bit about how multidisciplinary this research is as far as it, you made it sound very much like patient walks in and you can do this, but behind the scenes it sounds pretty hard as far as all the people you're interacting with.
Yes, I mean you can tell because I'm a dermatologist here at the presenting to the folks at the Abramson Cancer Center. So graft versus host disease is a incredibly complex disease because it can affect virtually any organ system. And so for the care of any single patient requires interdisciplinary care between many, usually with the primary being the oncologist, hematologist, who is also the transplant clinician, but then many subspecialists ranging from ophthalmology to oral medicine, dermatology, pulmonary, gastroenterology. So in terms of clinical care, there's extreme coordination. But on the research side, there's also, investigations both in GVHD overall, so folks doing biomarker development in the blood, and then folks in the subspecialty areas doing tissue and organ specific GVHD research. And up to this point, there's been quite a disconnect between what's been shown in the blood and in the end organ tissues, like the lung or the skin. And so, our hypothesis is that for these patients with at least severe skin involvement, we will need a skin specific biomarker.
Really cool. So I know that GEPs or gene expression profile assays are making their way into clinical practice, already being used in breast cancer, being tested in melanoma. So I'm happy to hear you're working on this. Thanks so much for the exciting work. We're going to turn to Sarah Gitto, who's going to talk about how imaging along a radionuclide therapy, along with immunotherapy, can be used to attack ovarian cancer. Sarah?
Good afternoon, and thank you to the Abramson Cancer Center Breakthrough Challenge and all of you here today for supporting my research and inviting me to present. I'm very excited to be here. But first, I'll introduce myself. I joined the University of Pennsylvania as a postdoctoral researcher in 2018, and now I'm a new faculty member in the Department of Radiology. My independent laboratory officially opened in November of last year, and our focus is on identifying novel treatment strategies, both immunotherapy and molecular targeted therapy to treat ovarian cancer. And so, why are we focused on ovarian cancer? And it's because it remains a devastating disease for women. It's the leading cause of gynecological malignancies, mortality, and also approximately 50% of the patients unfortunately die within 5 years of their diagnosis. So, new treatment options are desperately needed for women with ovarian cancer. PARP inhibitors, which we study in the lab, are a newer class of therapies. They were originally FDA approved to treat ovarian cancer in 2014. These are small molecule inhibitors that target the PARP protein and disrupt how cancer cells repair DNA damage as they divide. And this can lead to cell death in cancers that have specific mutations, including a common mutations often found in the genes for BRCA1 and 2. However, many cancer from these patients either do not respond to this treatment or eventually become resistant to PARP inhibitors. So our research is really focused on a new type of PARP inhibitor. Instead of relying on the drug's activity to disrupt the DNA repair process, ours is bound with a radioactive molecule and can now be used to deliver radiation directly to the PARP protein, which is often overexpressed in many types of cancer, including ovarian cancer. So this is really an exciting method to treat ovarian cancer, since ovarian cancer is typically sensitive to radiation therapy, but traditional radiation therapy is not often used in the clinic because most patients are diagnosed at a late stage when there's already spreading throughout the lower abdomen. And really, you need too much traditional radiation therapy to safely treat the patient. But by targeting the radiation directly to the cancer cell using a PARP inhibitor, we can exploit sensitivity to radiation in this cancer type. So you can really think of this as traditional radiation like a flashlight. The light's broad and diffuse, where the radiotherapy is more like a laser beam, strong and going straight to the tumor for precision therapy. So the radioactive molecule that we use emits alpha particles, and these alpha particles have a very short range, which actually helps to spare the normal healthy tissue surrounding the tumor. But it's also very powerful, causing a lot of DNA damage, ultimately killing the target cells. So indeed, our research shows that this targeted alpha therapy is very potent in ovarian cancer in both cell lines and patient-derived models. Treatment with the PARP targeted alpha therapy actually increases the potency of the drug an average of 30-fold more compared to the treatment with a non-targeted alpha therapy. And this really supports the importance of the binding of the radiation to the PARP inhibitor to deliver that radiation directly to the cell. Also, our results show that ovarian cancer is sensitive to this therapy, even if they're resistant to standard of care therapies, including chemotherapy or PARP inhibitors, or regardless if they have these mutations like in BRCA1 and 2. We also see sensitivity to this therapy in ovarian cancer cells that are known to have genetic alterations that cause them to be very aggressive and also resistant to standard treatment options. In our preclinical mouse models, we saw that treatment with our PARP-targeted radionuclide therapy reduces tumor burden, delays time to progression, and increases the overall survival, ultimately curing some mice of all disease for up to 100 days, which is the time that we ended these studies. The results we were able to replicate in both solid tumors and metastatic models where disease is presenting throughout the abdomen. So overall, these results support this is a really exciting new effective treatment strategy for ovarian cancer. And we see a broad range of activity across genetic alterations, primary and metastatic disease, and tumors that are both sensitive and resistant to standard of care therapies. So we're very, very excited about therapeutic potential in ovarian cancer and other PARP overexpressing cancers. And with that, thank you for listening.
Wow, that sounds amazing. You're curing all the mice with this radionuclide. What is the next step? Are you close to a paper? Are you thinking of a larger grant?
Yeah, so there's a couple things. So yes, we're working on the paper now. We're hoping to have it submitted by the end of the year. Yes, we're of course working on larger grants, and but for the research specifically, so I mentioned that we see that a number of the mice across these studies have completely curative responses, and that's very exciting. However, we also see that there's a select set of mice where the tumors do come back after treatment. And so we've actually identified a mouse model where only 20% of the mice are completely cured. And so we believe that by including an immunotherapy after treatment can increase this cure rate. So our results show that after treatment with the alpha therapy, the tumor cells do upregulate the immune inhibitory ligand PD-L1. So we're currently testing if blocking this immune inhibitory pathway with immune checkpoint inhibitors can reduce the tumor relapse. So one of the challenges is that the immune cells are the normal cell type in the body that has the highest levels of PARP expression. And so PARP inhibitors, as well as the alpha therapy, do target the immune cells. So we've spent actually a considerable amount of time optimizing the treatment strategy, especially the timing for when to administer the immunotherapy to have the greatest effect. And based on our studies, we now know that after treatment at the maximum tolerated dose of the alpha therapy, the immune cells begin to recover within 1 week after treatment, and they're fully restored to normal levels by 28 days. And this is actually quite comparable or even faster than standard chemotherapy. So quite promising. So right now we've identified an appropriate mouse model to test. We've optimized the treatment scheduling. And so now we're ramping up to test this combination therapy over the next couple months. And so we're really excited to see the results from this study and identify if immunotherapy can enhance the overall response rate. So more to come very soon.
That's so exciting, Sarah. So thank you so much for sharing your research. We're going to move on to Carmen Lee, who's going to tell us about breast cancer and identifying what are the main drivers of specifically the harder to treat breast cancers.
Hi, everyone. Can you guys hear me?
Yes.
That's great. So yeah, thank you very much. So I'm a new assistant professor in the Department of Cancer Biology. I started my lab about a year ago, and I'm also, besides being part of the Abramson Cancer Center, also part of the Basser Center for BRCA to study hereditary cancer development. And so my lab is interested in studying the development of inherited cancer or hereditary cancer, which are driven by inherited mutations from either or both parents in specific genes that are responsible for suppressing the development of cancer. And this can lead to very high cancer risks in various organs. And we're interested in studying that both under a baseline condition and also under stress conditions like with pregnancy, obesity, and aging. And our hope is to understand the molecular drivers of the high cancer risks in these individuals who inherited specific mutations and also explore opportunities for early intervention. And so today I'll focus on a big foundation of our lab, which is to study BRCA1 associated breast cancer. And we know that BRCA1 is an important gene to inhibit cancer by repairing DNA damage and preventing the accumulation of damaging mutations that can lead to formation of cancer. We know that people who inherited a single copy of an inactivating mutation in the BRCA1 gene, as shown here in the bottom, have much higher chance of developing breast cancer in their life, also tend to be of a much earlier age than the general population. And the usual thinking to explain this high cancer risk is what is called a two-hit hypothesis, proposed about 50 years ago by Dr. Alfred Knudsen to explain this high cancer risk. And it goes by saying that because the individuals who are born with already one inactivated copy of the gene, those individuals only have one remaining functional copy, and therefore only one more mutation away from full loss of function of the gene before cancer arise. And that's more likely to happen than the general population, which carry two active functional copies of the genes and therefore requires two independent mutations, not just one, to inactivate the gene, which is a less likely event. And so that's an intuitive probabilistic model that makes a lot of sense. But I was interested in exploring if there are additional mechanisms, a non-mutually exclusive explanation for this high cancer risk. And so to answer that question, we made various studies. And what we eventually found was that these BRCA1 heterozygous state actually contain abnormalities that act independently from the timing of full gene loss that accelerate cancer formation. And what we actually found is that the way that the DNA is packaged in the BRCA1 mutation carrying cells look very different from the breast epithelial cells in the general population, in the sense that these DNA packaging actually resemble a pattern that is found in the cancer cells. And we think that this more accessible and open pattern of the DNA packaging allows for genes that can promote cancer development to be turned on much more readily, and therefore that can accelerate the process of cancer formation. And one immediate question that we want to ask based on this finding is that can we use this information looking at the open regions of the DNA to identify specific proteins called transcription factors that can take advantage of this altered abnormal pattern of DNA packaging to promote, to turn on the expression of genes that can promote cancer development. And so I want to give you a taste of what we have done using our data of the open DNA regions to identify specific transcription factors that can regulate these pro-tumorigenic gene expression, with some examples showing here SP1 and RUNX2 as two transcription factors. There's a lot more that I don't want to show too much data on one slide, but as these two examples demonstrate, when we inhibit the expression of these transcription factors in cancer cell lines and look at the effect of the growth of these cells in a cell culture dish, we can see that inhibition of these transcription factors can lead to substantial inhibition of the growth of these cells over a multiple day time course. And when we put some of these cells into the mice, into the mammary gland, we can see that these cancer cells with inhibition of the transcription factors also have much delayed growth of the tumors compared to the control tumors over time. And so we think this is quite an exciting approach for us to identify these molecular drivers that regulate the cell state in terms of gene expression to identify players that can regulate the early drivers of cancer development. And in the long term, what we're interested in doing is identify this early window of opportunities where these transcription factors are activated so that we can find out ways to detect a disease early and also intervene early. And if we can understand this process of the abnormal chromatin DNA packaging from developing in the first place, we can also find a way to reverse that process and reduce the cancer risk of these individuals who are born with BRCA1 mutation. And potentially we can extend this to other cancer types that are affected by BRCA1 mutations, not just in the breast, but other cancers that are also high risk, like in the ovary, for example. So that's all I have. And as a new lab, we're super grateful for the support from foundations like the Breakthrough Challenge. And because of this, we're able to get some of our early works going. So I'm very grateful.
Thanks so much, Carmen. Transcription factors have been traditionally really hard to target with drugs. Can you talk about what some exciting things happening outside of BRCA1 that might intersect with this?
Yeah, for sure. So that's a good point about transcription factors being difficult to target, although the technology has improved a lot. We're also hoping that with identifying the downstream genes that are turned on by these transcription factors, we can look for key players and block them from there.
That sounds great. So interesting with this high-risk population and how you're going to be working on cancer interception. Let me introduce Donna Silverbush, who's been working with the glioblastoma team. So now we're talking about brain cancer and also CAR T cells. So not that off for me. So go ahead, Donna.
Thank you. Thank you, Ravi, and thank you everyone for your support and for allowing me to share our results, our very exciting results, which were assisted by your support, and how we found that we need to wake up the natural killer cells, and we need to team up with the immune system to fight brain cancer, as Ravi mentioned, and specifically glioblastoma. So as I imagine you probably know, brain cancer is a very aggressive type of cancer, and glioma or glioblastomas are especially aggressive. There is no cure today, unfortunately. Almost all patients do succumb to the disease, and there is a lot of effort trying to find something to prolong their survival, to ease their process, and to give hope to these patients. The University of Pennsylvania is famous for immunotherapy, and specifically CAR T cell therapy was invented here. It is very powerful with leukemias and used worldwide. And our next challenge in this is to apply it successfully to solid tumors. So here we started with glioblastoma, and even though it's a very aggressive tumor, there is something unique about the location that enables or that gives more hope for CAR T cell therapy to succeed. So the way that CAR T cell therapy is infused into brain cancer is through a device put on the scalp of the patient by our neurosurgeon, and then they fuse the cells into the CSF, so some fluid that we have in the brain. And from there, the cells find their way into the tumors and supposed to recognize and kill the tumor. So these CAR T cells, the T cells that are engineered to find the tumor, the question is, are they doing what they are supposed to do? And we started a clinical trial here in the university, in the hospital, where we treated 18 patients with these new cells that were specifically designed for each of the patients. So we started with recurrent glioblastoma. It is very aggressive. Patients are usually can expect maybe 6 to 9 months of survival. Tumor progresses immediately. It always grows. And you can see each column here is a patient. Some of the patients, indeed, the tumor grew even after treatment. But for 62% of the patients, we saw tumor shrinkage, which you would never see at this stage of the disease. So that was surprising, encouraging, and now has been recaptured in other centers around the world. But the question is, how can we use it to get better therapy? How can we make everyone respond? And how can we make the response more durable? And that's where your support came in. Our lab had received longitudinal samples from the tumor and from the CSF before and after treatment. So we get the tumor itself and immune cells that are around the tumor, and we can characterize them to understand what happened. And we use that first to answer the very important question of whether these CAR T cells are activated. Do they actually find the tumor and manage to kill the cells? And indeed, we found that they were activated, and this was across all the patients. For every patient, responder and non-responder, the CAR T cells were activated. But what was really important is also that they managed to wake up the immune cells in the body that were not part of the treatment. It was also important to understand which type of immune cells were waking up. So the CAR T cells were infused through this device, and they were active. They were doing what they were supposed to do, killing the tumor cells. But two other types were waking up as well. The natural killer cells that are good immune cells in our body that can kill the tumor cells further, and they came as a second wave, and that was very helpful for the patients. And then another wave of regulatory T cells. These regulatory T cells are very important for healthy individuals. We don't want our inflammatory processes to overactivate. So regulatory T cells quiet them down, dampen the immune activity. But in this setting, it was not good. It was dampening the immune activity that was killing the tumor cells. So these two were waking up, and they led to the response of the patient. Here we are seeing on the x-axis the amount of immunosuppressive Treg cells waking up, and on the y-axis, these natural killer cells. And so for each patient, the response was dictated between the balance of these immunosuppressive cells versus the natural killer cells. We can see patient 5, for example, here, a lot of immunosuppressive regulatory T cells were waking up, and this patient was not doing well. Non-responders, we see the size of the cycle indicates how many months the patient survived, and so they didn't survive for very long. But for other patients where natural killer cells were waking up, such as patient 7, 9, 3, 4, all of these patients, this balance was tipped, and the natural killer cells were able to kill the tumor cells, and they lived much longer than expected. And in fact, for some of them, they are still alive today, 2 years after, which is quite reassuring. And as a researcher, also makes me very happy to know that we can help these patients. So we understood what was happening, but beyond that, that informs the next step of therapy. Right now, we have the CAR T cells that we engineered to recognize the cancer cells. But we can do something more now that we understand the mechanism. We can do something that is called armoring. So we put an armor on the CAR T cells, and this is a signal, a specific signal that knows to wake up the natural killer cells and calls them to join the fight against the cancer cells. And we can armor them with a signal that inhibits the regulatory T cells and tells them to continue sleeping. And that should boost the response, and it should make it more durable. So I'd like to thank you for making this possible, for your very important donations.
Thanks, Dana. So really interesting. We've had a chance to work together. Tell us about how your discovery could impact other cancers.
Indeed. So we think that the same mechanism could help with other solid tumors. The next step, the next obvious step, I think it would be to try this with brain mets, such as melanoma brain mets, which I think would be a very, very exciting next step because the delivery would be the same. And in fact, the CAR T cell design would be very similar with the same kind of processes happening. And so we can translate what we understand from brain cancer to melanoma brain mets, to breast cancer brain mets. This would be the immediate next step. Then eventually the tools, the understanding that we gain here could also help us understand how to use the same technology to treat other solid tumors in the body.
Really exciting. Yeah, we have a problem with brain mets and melanoma, so I'll be talking to you soon.
Love that.
Let's turn our attention to now Roddy O'Connor, who will be talking to us about the metabolic fitness of CAR T cells.
Okay, thank you. Let me set up. Okay. Yeah, great to chat with everyone. Excellent research so far. Really, mine is about performance edge and metabolic fitness, as Ravi said. So Citius Altius Fortius is bigger, stronger, faster. Can we give CAR T cells a performance edge? When CAR T cells are manufactured, it is a kind of a simple process where T cells are isolated from a patient, and we view the T cells as soldiers. They're really specialized assassins, and we give them a weapon, which is the CAR, and it redirects them, allows them to hunt down cancer cells when we, kind of mount this task force back into the body. So we expand them. Our goal is to confer unique metabolic properties and advantages to them before they're reintroduced back in. So in the theme of the, performance edge, I always have the five Olympic rings as a background. And we can fill these in terms of T cell fitness and kind of the metabolic nature of the environment that they have to work in or function in. There's a picture there of Carl June on a bike in very hostile conditions, which is similar to the battlefield the T cells have to go in and kind of work against. And the picture on the bottom left is a former breakthrough bike ride a few years back with Carl in there. I'm in there as well. We've shown previously that if we confer enhanced metabolic fitness to the cells vis-a-vis mitochondrial function through CAR design, that we get superior engraftment, persistence, and this idea of long-lived immune surveillance, which, if cancer ever reappears, that there'll be cells there to tackle it. We are focused in with the project where we, utilize the resources and funding of the Breakthrough Challenge Research Award. We focused on ovarian cancer, much like Dr. Gitto introduced in her talk. This is once again a very hostile environment or battlefield for the CAR T to work in. These assassins are soldiers. It's a liquid tumor environment, which is kind of unique. We often hear of things like a solid tumor microenvironment. This is mainly liquid that's highly suppressive, and it's kind of this murky broth, which we can characterize really well by lipidomics, a mass spec-based technique. And we identified that it's got really a unique metabolic profile, and it is this exact profile that puts the brakes on our assassins or on the T cells. And we did identify what I would call smoking gun or a smoking gun, which is a distinct lipid species within this murky broth of the tumor environment that is highly suppressive to T cells. So it impairs the functional competence of these soldiers when they're, traversing the battlefield. We showed that using this kind of smoking gun analogy, if we identify a lipid class that's suppressing or putting the brakes on the T cells, how it does it. It can physically weave its way into the cell membrane of the T cell, and in doing so changes properties like fluidity and the clustering of receptors that direct all responses of the T cells. So it really changes the tensile properties, the fluidity, and the biophysical organization of the T cell interface with the tumor cell within that battlefield. So really, this is a summary of things that we found. Using funding from the award, we focused it on our lipidomic studies to identify a smoking gun and a specific class of metabolites that the tumor is utilizing to support its growth, but at the same time impair or inhibit T cells, our soldiers. And the next step will be kind of innovative solutions to overcome suppression in this battlefield. And we always say it takes a village, and it does. So there's lots of collaborations here that support this advances. So I'll finish there on that summary of the work.
Thanks, Roddy. Did your work uncover any sort of hints as to anything that patients can do for nutrition with CAR Ts when they're getting CAR T cells, or is it not there yet? Or
Yeah, that's a great question. We're certainly looking at it in terms of a broad range of malignancies. We're looking at the serum metabolome because that's even different in patients and it's easier to access, and there's biobanks at Penn. So we're looking at what factors are different there. So I'll say in certain responders and other malignancies, not per se this ovarian cancer, creatine has emerged as a factor that was not predictive, but it was upregulated in the serum of responders. So there's certainly, kind of hot metabolites that could be nutritionally regulated that may support, diet as a factor that could be helpful in a combinatorial strategy, so to speak. Yeah.
awesome. Well, I think we've stayed on time, or maybe a minute off, but we have time for questions from the audience. So please use the chat to populate questions. There's one question already about photopheresis for the GVHD patient. Was that tried? That's the only therapy that worked for the person that posed the question. So I think that was Emily.
Yes, it's a good question. Yeah, that is one of the treatments that we tried and is often one of the ones we cycle through for chronic GVHD. So it's a good question.
Right. And then I don't know the answer to this, but maybe Donna, you might. There was a presentation last year about a hydrogel for GBM. Is that moving forward?
It is, yes. It is such an exciting avenue. So the idea is that instead of infusing all the cells at once with the hydrogel, you can infuse them slowly. And so you get less toxicity and more durable response. And we collaborate with the clinical team to engineer these hydrogels. I'm really excited about this question, about this improvement.
Great. And I'll just take, there was some questions that just came in before this. And I think we heard a couple of talks on ovarian cancer. And the question, I'll open it up to the ovarian cancer researchers. What treatments have proved most successful for dedifferentiated uterine or ovarian cancer?
Yeah, treatment-wise, I don't know exactly, but I know that in our hands, preclinically, what we're showing is the abbreviated manufacturing regime for CAR T cells. So CAR T cells used to be expanded for 9 to 14 days to get more numbers of soldiers. We're changing that to day 3, so it's abbreviated. You don't want quantity, you want quality. So having fitter cells going in, for adoptive transfer is giving far better potency and better responses. So for cell-based therapies, earlier and fitter cells seem to be the way to go.
Great. And then there's just a question that came in. It sounds like there's a lot of common themes. How does the Abramson Cancer Center promote, quote, water cooler exchanges? So I'm going to take that as Director of Translational Research, and then all the speakers can also chime in if it resonates. But we have really pushed hard for inpatient meetings. Uh, of course, we still do a lot of Zoom meetings, but we've found recently in the last couple of years after, recovering from COVID, that people are longing to do the water cooler exchange. And an example of that is we've started something called Dinner and Data, where the clinical side of the hall is going to invite the basic side of the hall on a specific topic, let's say RNA therapy, and they invite the best experts on RNA therapy to serve as sharks in a shark tank. And then they invite other people to present projects. And this is where you hear about projects you might not hear about, and you get a quick review of your project and suggestions in a friendly fire kind of way. And that has led to a number of collaborations. For instance, the collaboration between Donna's group, the GBM group, and the melanoma group came out of that Dinner and Data. So it is more structured than a water cooler exchange, but people are finding those in-person interactions good enough that they are hanging out at the water cooler more and looking for these, by chance interactions as well. So I'll open it up on that topic to anybody else if they want to chime in.
I can add to that actually. We just acquired new space in the CCI, and when we were talking about what equipment we would need, Carl June was on the call, and he immediately said, "I'm going to fund the coffee machine. I want a coffee machine. I want people rubbing shoulders at the coffee machine. This is where ideas happen." So that was the first thing he said. So I think that's hits the mark there.
Great. With that, I think we will turn it over to Bo Eby, who's got some closing remarks. So, Bo.
Great. Thanks very much. And I'm just going to jump in on that comment about funding the coffee maker. One of the great joys of the ride is the ability to catch up with the breakthrough community, mingle with the leading researchers in the nation, find out what the latest breakthroughs are, see patients who have been successful, and honor those for whom we weren't able to find a treatment at this point. Ravi and colleagues, we very much appreciate the long hours that you put in, the innovation. When we started this 13 years ago, we like to say we were funding hope and you were providing hope. You're still doing that, but you're also providing actual successful treatments, which is extremely rewarding. We enjoy the ride. This year's ride is September 27. As I said, it's an opportunity to catch up with the breakthrough community, an opportunity to sneak in one last day of summer. We're extremely proud of the fact that 100% of the rider raised funds go directly to research. We don't use that for overhead. The board is committed to raising the funds to put on the ride so that all the money that the riders raise goes directly to funding the great work that you do. We're also delighted, Ravi, you mentioned that you were able to leverage your grant into further research, and we love to hear that. So thank you all for attending today, and we look forward to seeing you on September 27th.